Thank you. At this time, I will call to order the Assembly Committee on Health and Human Services today. For those of us joining us online, please make sure that if you are on the Zoom that you mute your microphone unless when you are not speaking to minimize any background noise. And I'd also ask you to turn on your cameras if you are on the Zoom, because if you don't, unfortunately, we have no way of knowing you're on the Zoom. So thank you. Madam Secretary, if we can please call the roll.
Assemblywoman Benitez-Thompson. Assemblywoman Black.
Here.
Assemblywoman Gorlow. Here. Assemblyman Hafen.
Here.
Assemblywoman Krasner.
Here.
Assemblyman Matthews.
Here.
Assemblyman Orentlicker.
Here.
Assemblywoman Peters.
Here.
Assemblywoman Summers Armstrong. Assemblywoman Thomas. Here. Assemblywoman Titus. Here. Chair Wynn.
Here. And I will also note that Assemblywoman Summers Armstrong is also present. And if we can mark Assemblywoman Benitez-Thompson present when she arrives. At this time, I welcome again our audience joining us for this virtual meeting and in-person meeting of Assembly Health and Human Services. Today we have two bill hearings. I will tell you, I think we are taking them in the order as listed on the agenda. And at this time, I will open the bill hearing on Senate Bill 251. Oh, I am taking them out of order. I'm sorry. Senate Bill 251. Welcome, Senator Gansert, and please begin when you are ready.
Thank you, Madam Chair and members of the committee. Again, I'm Senator Heidi Sievers Gansert. I'm a senator from District 15, which is in northern Nevada. Today I'm joined by Dr. Nathan Slotnick and my friend Abby Whitaker. I want to give you a little background on Dr. Slotnick first, and he is an expert in genetics, so he will be talking at length about hereditary mutations for the BRCA1 and 2 genes. So Dr. Nathan Slotnick is a medical geneticist and a high-risk obstetrician, and he's board certified in both disciplines. He's also seen many pediatric and adult obstetric patients for 18 years and was relocated to Nevada in 2003. In 2005, he was asked to start a cancer genetics program by a local oncology practitioner group. That group has actually grown dramatically with a total of more than 4,000 cancer patients seen. He's also been a University of Nevada Reno School of Medicine faculty member and has been widely published on a number of cancer genetic and high-risk obstetric topics. In November of 2020, he was named Medical Director of the Reproductive Genetic Medicine at Invitae Corporation, a large international genetic testing and services organization. I also have with me, or on Zoom there, Abby Whitaker, who's a longtime friend of mine. She's a well-respected and award-winning communication specialist and entrepreneur who founded her own business, the Abby Agency, with her husband Ty. The Abby Agency's tagline is where chutzpah meets acumen, which perfectly describes my friend. What many people don't know about Abby is that she's also a cancer survivor. So since Abby's with us today, I'm going to have her share her own story. But what I will say is that when Abby first called me about sponsoring a bill around BRCA, I said I absolutely would do it, of course. I realized that she was one of about a half dozen friends who I personally know who've been affected by the BRCA1 and 2 genetic mutations. Each of my friends had cancers at an early age or had a family history and possible genetic link, but it had not been connected. They were not told, and so their diagnosis and sometimes were quite late. The screening, referral, and testing that's contemplated in this bill is very important for each woman, and it's also critical for the families of women who have tested positive for BRCA mutations. I'd now like to ask Dr. Nathan Slotnick to go ahead and give us a brief review of BRCA1 and 2 mutations, and then I'll ask Abby to tell her story. Thank you.
Good morning. My name is Nathan Slotnick. I'm a medical geneticist. I will share my screen in just a moment, but I'd like to take a moment just to introduce myself. I have had many very pleasant years working in Nevada. I've been licensed to practice in Nevada since 1990. That's a long time ago. And as Senator Gansert has mentioned, I've had a long-standing and abiding interest in cancer, hereditary predisposition, testing, molecular genetics, and ways of offering these opportunities to both clinicians and patients in the state of Nevada. I'm honored to speak to you today, and I will be happy to answer questions. I put together a short presentation which will detail the clinical and the scientific background that allows us to address these issues, and I'll be starting my screen share now. Let's see if I can do this without screwing it up. And good. Is that visible? Can you hear me?
Yes, it's visible.
Oh, very good. Thank you very much. It's always hard to talk to a non-existent audience, so thank you very much. So today we're going to address the issues of genetics and genomics in cancer, but I'm going to put a plug-in at the end of my presentation about how the technology that allows us to have this discussion today is applicable to virtually every other clinical entity in medicine, and how we should really consider it when we think about future directions that medicine and medical practice will take. Let's start first talking about the genetics of cancer and talk about what the etiology or cause of cancer really is. Now, cancer is due to an alteration in the DNA of specific genes within specific cells of the body. If the alteration occurs within one of the many cellular control genes, normal cellular control can be lost. That damaged cell reproduces into more control-less cells, and a tumor can develop. Further loss of control results in spread away from the original cell's location. That's called metastatic disease. Therefore, and this is an important distinction, all cancers are genetic, in meaning that they have a DNA etiology, but not all cancers are hereditary. In every sense, then, cancer is a genetic disease. Now, let's talk about what that really means. Now, every geneticist that I've known from all these years that I've been in practice has the habit, I guess, of whenever we come across something unusual, we have a file cabinet, we put it into the file cabinet, and when we get a chance to look back at it, or when technology advances, we're able to make some statements in that regard. Starting in the 1950s, genetics doctors have put into their file cabinets very interesting family trees having to do with cancer. And what they found, in particular, something called hereditary breast and ovarian cancer syndrome, or HBOC, is that each of the family trees have specific predictions that they manifest. Hereditary HBOC family trees generally show breast cancer before the age of 50, ovarian cancer frequently at any age, male breast cancer, which is really, really rare otherwise, frequently multifocal or bilateral breast cancer, and frequently associated with certain ethnic backgrounds as well. These can be contrasted with non-hereditary types of cancers, which don't have these particular characteristics. HBOC has evolved, as we learn more about it, into a direct association with breast BRCA, or breast and ovarian cancer syndrome, BRCA1 and 2 genes. Now, let's take a look at what this really means in a clinical context. By age 40, 1 in 200 women in the population will have developed breast cancer. But if you have a mutation in BRCA1 or BRCA2, it's more likely 10 to 20% risk of breast cancer will occur. By age 50, 2% of the population of women will have breast cancer. A BRCA mutation will increase that dramatically to 33 to 50%. And over a woman's lifetime, 12% of the population, women's population in this country, will develop breast cancer. But with a BRCA1 or 2 mutation, that risk goes to 56 to up to 87%. Now, these ranges occur because different studies make different predictions, but one way or another, this is a huge increase in risk of developing breast cancer. It also affects the development of ovarian cancer. Approximately 1% of the female population in this country will develop ovarian cancer during her lifetime. But with breast BRCA1 or 2 gene mutations, those risks go up dramatically. And I'm sure all of you know that ovarian cancer is frequently not diagnosed until it's disseminated through the body, and it's very difficult, if not impossible, to treat. If you look at all of the HBOC patients, you'll find that approximately 85% will have either a mutation in BRCA1 or BRCA2. However, it's become obvious that there are many other genes involved in this hereditary predisposition as well. And I'll be getting back to that in a few minutes. But it's more than just the development of cancer. It includes considerations of the development of a second independent cancer. 5% of all women who will develop breast cancer within 5 years of the original diagnosis will develop a second breast cancer. But if you have a mutation in either BRCA1 or BRCA2, that number goes to 12 to 20%. Over a woman's lifetime, if she develops breast cancer, the risk of a second primary breast cancer is about 11%. But with a mutation in either BRCA1 or 2, it goes up to 40 to 60%. So knowing a patient's BRCA status is crucial in knowing how to treat her well, how you treat her medically. But it's more than just recurrent disease as well. Now, male breast cancer is remarkably rare. But if you have a mutation in BRCA1 or 2, especially BRCA2, that risk goes up to 7% of the male population will develop breast cancer. Prostate cancer risks go up dramatically. We are currently recommending BRCA1 or 2 testing for every prostate cancer patient. Melanoma risks go up dramatically, and pancreatic cancer risks go up as well. And we are currently recommending BRCA1 or 2 testing for patients diagnosed with pancreatic cancer. Why are we doing this? Well, obviously, knowing in advance makes it easier to identify patients at risk and surveil them differently. But it's more than that, too. We know that if you have a mutation in BRCA1 or 2, something as simply as administering tamoxifen, which is a medication, will reduce that patient's risk of breast cancer by 50%. Ovarian cancer risk can be modified as well. Something as simple as the patient taking birth control pills can reduce the risk of that patient developing ovarian cancer, even if she has a BRCA1 or 2 mutation, by up to 60%. You can do more. We know that we are currently recommending patients with BRCA1 or 2 mutations, we're recommending that they consider bilateral mastectomy as a risk-reducing prophylactic measure. Usually this discussion is recommended with a breast specialist and can be done within the 40 to 60-year-old age range. And that can reduce risk dramatically as well. We know that we can further reduce a woman's risk of breast cancer by removing her ovaries and her tubes, usually recommended at age 35 to 40. And we know that we can reduce the risk of an ovarian cancer development by removing a patient's ovaries and fallopian tubes, reducing the risk rather dramatically as well. And usually this is discussed in the 35 to 40-year-old time range. Now, let me try to present the concept of more than one gene is involved here. This is not difficult. Every human adult has approximately 30 trillion cells in their body. Those 30 trillion cells are the results of many, 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 many cell divisions from a single fertilized egg. Every time a cell divides and there are two products, we kind of assume that those two products should be genetically identical, but they're not. Every time a cell divides, the 3 billion base pairs of DNA that are in the mother cell need to be reproduced, and we know that mistakes happen. The fidelity of replication of DNA is imperfect, so that every time a cell divides, instead of having 2 genetically identical daughter cells, you have 2 daughter cells that are not genetically identical. Every time those errors occur, one of the types of errors, as you can see on the left side of the screen, is something called a DNA double-stranded break. And every time that occurs, all of the genes that are listed here in pink and blue and gray are called to attention, and they work together to attempt to repair the mistake that happens during cell replication, that DNA double-stranded break. And if everything works well, the repair works fine, and we're back to a normal state. But anytime there is a mutation in any one of the genes that you'll see here, mistakes are not corrected as easily, they can accumulate, and cancers can occur. So when we talk about genetic testing, although we are focusing today on BRCA1 and BRCA2, which are sort of halfway down the slide here in pink, we need to also consider all these other genes that are potentially related to the inability of DNA repair and the development of cancer. Now, again, what is the process here? Well, we use a sequencing tool. Remember, of the 3 billion base pairs of DNA, when we look at the DNA and judge whether there are mutations, we sequence that DNA. The cost of sequencing the whole human genome 20 years ago was $100 million, up to $300 million. And those numbers come out of the Human Genome Project. I'm anticipating that within the next few years, we'll be able to DNA sequence a whole human genome, clinically use that information for less than $500. And it's going to create some rather dramatic changes in our ability to identify patients at risk, not just for cancer, but for cardiovascular disease, developmental delay in children, birth defects, many, many other conditions as well. And it's all because these sequencing tools have become much more powerful and much, much, much less expensive. Now that ends my presentation here, but I'm more than happy to answer questions.
Thank you. Senator Ganser, do you have any other follow-ups, or are you ready for questions?
My friend Abby Whitaker is also
Oh,
on the
yes,
line.
yes,
Okay.
I'm sorry.
And I just wanted, so thank you, Dr. Slotnick, for going over that with us. I think we have a good understanding. There's just 2 numbers I want you to remember from that presentation, 87 and 44. If you test positive for BRCA1 or 2 during your lifetime as a woman, the odds of you getting breast cancer are as high as 87%. If you're positive for BRCA1 or 2, your odds are as high as 87% that you'll develop breast cancer and 44% for ovarian cancer. And now if my friend Abby Whitaker can talk a little bit about her story. Thank you.
Go ahead when you're ready, Abby.
Hi, thank you guys so much. Hi, my name is Abby Whitaker. As Heidi mentioned, I am a cancer survivor. I had cancer 10 years ago. It wasn't breast cancer, actually. It was an HPV-related cancer, but it kind of leads into this story. So I've been getting mammograms for 5 years, and then this year I switched to Reno Diagnostic Center for my mammograms, and they, for the first time, gave me a screening, which asked me some questions about my family history and flagged me for genetic testing. So my first question was, is it free? I don't want to pay for that. And it was free. So they gave me the genetic test and it came back positive for BRCA1 and for BRCA2, sorry. So I'd already been through chemo and radiation with another cancer. And for those of you that maybe have been through that experience, you know that the chemo and radiation is part of the crappiness, but the 5 years afterwards, waiting to make sure you don't come out of remission is also kind of a crappy situation as well. So when I found out I was BRCA2, I decided that I wanted to have a double mastectomy. I had a double mastectomy last Thursday. So I am 8 days out. I'm off the pain pills, which is why it was safe for me to come and testify today. I'm definitely not myself, but I am really, really glad that, especially after hearing Dr. Slotnick's presentation again, that I have the chance to do that. And I would have never known, even being a cancer survivor, if Reno Diagnostic Center hadn't asked me those questions and flagged me for genetic testing, I would have never known that I was BRCA2, and I would have never been able to make that decision to have a double mastectomy and take my healthcare into my own hands. So SB 251 is going to give every woman that chance through different types of screening. And I just think that as moms, as sisters, as grandmas, as legislators, right, we have so much on our plates, and we don't always know what's wrong with us. And this bill gives women a chance to know that and to make a decision like I did, to have a double mastectomy, or as Dr. Slotnick said, some of the other options. So I thank you guys for listening. I thank Senator Severs Cancer. I thank you for all the work you put into this, and all the co-sponsors I saw from all sides of the aisle. And I think women in Nevada are going to be healthier and better off because of this. And thank you guys very much.
Thank you, Abby. So again, for the record, Senator Heidi Severs Gansert. I can go over this bill in pieces, or I can basically tell you it does a couple of things. It raises awareness around the BRCA1 and 2 mutations a couple of ways, and it also makes sure that if a woman has a high probability of having the BRCA1 or 2 gene, which is a personal history or family history, they get referred for counseling and for testing. And I'll also tell you that under the ACA with the U.S. Preventative Services Task Force, that's covered. So this does not expand or require any more insurance coverage or any more payments. These types of services are covered. And the way that the awareness should go up is that when you go get a mammogram, you'll receive a notice. So right now you receive a notice if you have high density breast tissue. This actually adds another notice to make you aware that certain types of cancers are indicators that you should talk to your physician or your primary health care person, whether that's a nurse practitioner or whoever that may be, about potentially getting screened and getting tested. And then it also requires that your primary health care physician does that type of assessment, which they really should already be doing, but we're putting that in statute. So these types of services are already covered under federal law. We're putting this in Nevada statute to make sure that they continue to be covered. And again, I want to thank Abby for her story, and I'm going to tell you a brief one. I had a friend that I've known for about 25 years. I never knew her without cancer, and her second daughter's the same age as my oldest daughter. So I met her when our daughters were in first grade. And she died last year of breast cancer. And more recently, she was tested. So this connecting the dots that you could be BRCA1 or 2 is not always being connected to make sure they get the testing. Well, she tested within, like, say, the last 5 years and tested positive for BRCA. And while she ended up dying, what was so significant about her testing and getting the test is that her daughters needed to be tested. And by the way, when she was having cancer, breast cancer, fighting for her breast cancer one time, her sister was fighting breast cancer. So in the end, there are 6 cousins between the 2 mothers, and all of them are positive for BRCA. And I know one of them, who's 32 now, has already had a bilateral mastectomy because that's the choice that she made once she conferred with her physician. But women need to get tested so they know their risk, and then their daughters and potentially their sons need to get tested. And the male breast cancer is much lower. It goes up to about 7%, but the female, so that's significant as well. But women who test positive for this gene, and connecting those dots again is so important because the test is really easy and it's inexpensive and sometimes it's free. So thank you for your attention today. I'm open for any questions you have.
Thank you, Senator, and thank you, Abby, for sharing your story and being here such a short period of time after having a surgery. I think sometimes I realize how accessible we are this session under these protocol to allow someone to come here, share their story, make a real impact under the circumstances that you're in. So I do appreciate that. We do have a couple questions, so I'm going to start with Assemblyman Ornlicker.
Thank you, Chair. Thank you, Senator Ganser, for bringing this bill. Very much like it. And a couple things, if I could ask. Start on, one of the reasons why you're recommending this is because it's, proposing this is because it's a recommended screening by the United States Preventive Task Force. So that makes a lot of sense. So it makes me wonder, should we be thinking about broadening this? Are there other recommendations by the task force that we should be making sure doctors follow when they see patients?
Thank you for the record, Senator Heidi Severs-Ganser. And so we are focused right now on BRCA 1 and 2 because there are probably other ones that are out there. What is helpful for these is that they're covered by insurance. And so we want to make sure we at least address these two mutations because of the research that's been done and the obvious numbers. And I know Dr. Slotnick, when we first talked, he was interested in a lot of different mutations that could potentially be evaluated, but since these are the ones that are before us, we're focused on these, but I would say that there may be legislation in the future that could be brought forward to cover more.
Thank you. And second question on Section 1, subsection 3. So this is like page 2, I think, 24 to 26 lines, where you talk about sanctions for failure to comply. And no criminal penalties, that makes sense. No professional discipline. So I assume you're leaving open the possibility of a malpractice lawsuit for failure to comply. So is that correct reading? And 2, it seems a little odd that you could be sued for malpractice and found and held accountable, but not no follow-up for professional discipline.
So thank you for the record, Senator Heidi Severs-Ganser. So Chapter 457 is the Nevada chapter on cancer. And in that cancer, if you don't follow everything in there, and there's a variety of things, including like child support payments, you could have a misdemeanor or a felony. So what I was trying to do is make sure that physicians or primary care providers were providing these assessments, but not penalizing them with a misdemeanor or a felony, because this is something that they're already doing some family history, but this is a little bit more because you have to ask about grandparents and grandmothers and aunts and uncles and so forth. So it did not contemplate anything about malpractice insurance. This really is about trying to get women assessed and take the first step to see if they need to get genetic testing.
Thank you. And I'm just going to kind of look around here to see if there are any other questions. I see one from Assemblywoman Benitez Thompson.
Thank you so much for the ability to ask a question, Madam Chair. I appreciate the conversation on this, and it's so interesting because in the past decade, just watching how our legislation has responded to advances in medical care. So just starting off with even requiring mammograms in law, and then talking a couple years later about the issues around dense breast tissue, and having really hearty debates in this committee about how we respond to the new science that's coming out, and then being here with the BRCA testing. So just an observation that the evolution of our statutes to respond in medicine, sometimes we can't quite keep up with all the good things that are out there. The question I did have is on just for the record, so we could flesh out the continuing education piece for these. So I know typically, and I imagine what you would want, is that once enacted, the licensing boards would set the hours, attachments to whatever that continuing education was. That's typically how it works, where if you were in a, and these are the medical education units, like if the class you attend is 3 hours long, it's worth 3 hours worth of credits is the typical model. So I don't see any hours prescribed in here, and so I'm just assuming that the intent is for the board to, the licensing board to promulgate regs as they ordinarily would in regards to the amount of credits for the hours spent in that educational activity.
Thank you for the record, Senator Heidi Severs-Ganser. And so what I wanted to make sure is that if you take courses on genetics, that they qualify and are acceptable to whichever organization is your licensing agency. So I wasn't requiring a certain number of hours in genetics. I was what we wanted to do is make sure if you took classes in genetics that had been qualified, usually they're national organizations, that they would be acceptable towards the CMEs. And responding to your first comment, you and I know what a heavy lift some of those were to making sure mammograms were covered and prostate screens and so forth. So I'm really happy to bring this forward, especially because it's already covered at a federal level. But it used to be very difficult to have some of these things that really save money in the long term, but the preventative health services are truly important, so thank you.
Do we have any other questions? Okay, seeing none. Thank you, Senator Gansert. At this time, we will begin testimony in support, opposition, and neutral. I am looking around the room, and there's obviously no one else in here, so there's no one in person for testimony in support. Broadcast services, if we can go to the lines for callers in support of Senate Bill 251, I'd remind callers to please clearly state and spell your name and limit your testimony to 2 minutes. If we can begin.
To testify in support of Senate Bill 251, please press *9 now to take your place in the queue. Caller with the last 3 digits, 131, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Chair Wynn, members of the committee, my name is Connor Kane, CONNORCAIN, testifying in support of Senate Bill 251 on behalf of Comprehensive Cancer Centers of Nevada. We encourage your support of this important bill. Thank you.
If we can go to our next
Caller with the
caller.
last 3 digits. Oh, sorry. Caller with the last 3 digits, 199, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Thank you, Chair and members of the committee. My name is Tess Opferman, that's OPFERMAN, speaking on behalf of the Nevada Women's Lobby. We want to thank Senator Sievers Gansert for her hard work on this bill. Some numbers to do with the BRCA gene mutation. About 13% of women in the general population will develop breast cancer sometime during their life. By contrast, 55 to 72% of women who inherit the harmful BRCA1 variant and 45 to 69% of women who inherit a harmful BRCA2 variant will develop breast cancer. For ovarian cancer, it's also significantly higher for those who have the BRCA1 and BRCA2 gene mutations. These numbers are significant. Ensuring that women are screened and those that are at risk have the ability to get genetic testing is critical to preventative care. This bill will quite literally save lives. We urge your support and thank you for your time today.
Caller with the last 3 digits, 800, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hello, my name is Wes Falconer, spelling WESLEY, last name Falconer, FALCONER. I'm calling on behalf of Cancer Care Specialists in Reno, and real brief, we would like to express the utmost support for this bill, and we believe that the preventative screening is the way to go in all cancer treatments going forward.
Chair, there are no more callers in support at this time.
Thank you. At this time, I will see if there are any callers in opposition to Senate Bill 251.
To testify in opposition to Senate Bill 251, please press *9 now to take your place in the queue. Chair, there are no callers in opposition at this time.
I will go next to the Zoom. Is there anyone on the Zoom that would like to testify in neutral of Senate Bill 251? I don't see anyone there, so if we can go to the line, is there anyone in neutral?
To testify in neutral to Senate Bill 251, please press *9 now to take your place in the queue. Caller with the last 3 digits, 786, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hi, good afternoon. My name is Erin Lynch, ERINLYNCH, and I'm the Chief over the Medical Programs Unit at the Division of Healthcare Financing and Policy. So the division is testifying in neutral for SB 251, and within Nevada Medicaid, we already cover BRCA 1 and 2 screening, testing, and genetic counseling for women who meet the criteria of the bill and the United States Preventative Services Task Force. And so, therefore, we have a $0 fiscal note on this bill. Thank you.
Thank you. Do we have any other callers in neutral?
Yes, Chair. Caller with the last three digits, 616. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hi, my name is Saujanya Reganti, Sowjanya. Rasmus Reganti, Reganti. I'm a medical oncologist at Cancer Care Specialist. I would like to totally support this bill, and thank you to Dr. Ganser to bringing it up because it's very important for prevention and also it's with the family history and all that. So I totally support this bill. Again, this is Dr. Reganti from Cancer Care Specialist, medical oncologist.
And if we can, Madam Secretary, if we can reclassify that testimony from Ms. Dr. Regante into support testimony. I know sometimes people don't click on it fast enough. Do we have anyone else on the line?
Chair, there are no more callers at this time.
Senator, I'll turn it back over to you for any closing remarks.
Thank you, Madam Chair and members of the committee. And I want to thank Dr. Regante. She was seeing patients, and so was Tex to make sure she get on the line. And I also want to thank Ms. Lynch, who testified that there was a zero fiscal note. Again, this will increase awareness and help connect the dots so women who have the indications that they need to get some counseling and testing will get it. And the numbers are astronomical as far as your odds of getting breast and ovarian cancer and other cancers. So that's why it's so important for a woman and her families. So I appreciate the time today, and I would appreciate your support on the bill. Thank you.
Thank you, Senator. And at this time, I will close the hearing on Senate Bill 251, and I will open the hearing on Senate Bill 156. Senate Bill 156 revises provisions related to crisis stabilization senators. Welcome to Assembly Health and Human Services, Senator Ratty. Please begin when you are ready.
Thank you, Chair Wynn. It's my understanding that I'm running my own tech, so I may need just a brief moment to make sure that I can find everything on the computer that I'm supposed to be doing. So
That's fine.
Just a minute. Madam Chair, I have a 90% confidence rate that I might have it.
Fingers crossed. Go ahead and begin when you're ready.
Thank you. Hello, everyone. My name is Julia Ratty, and I represent Senate District 13, which is in the heart of the Northern Nevada Reno Sparks area. I kind of have the middle, which includes downtown Reno, downtown Sparks, the university, to give you the general idea of the district that I represent. I'm very proud to be here today to present to you Senate Bill 156, which is one component of several that I will be bringing forward to you hopefully over the course of the remaining portion of the session, that seeks to address basically rebuilding the way that we respond to a person who is experiencing a behavioral health crisis. So I have a 30-minute video that I'd like to show you. It's a 4-minute video that I would like to show you. That is an overview of how we could look at behavioral health crisis that hopefully will run. So if you could just give me a minute.
It's been a bad day. You've been in a bad car accident or experiencing chest pain. Fortunately, there is an emergency medical system built to respond immediately to your crisis. Now rewind. It's been a bad day. But this time it's due to a mental health crisis, like thoughts of suicide. The same emergency medical system that responds to chest pain also responds to this type of crisis and is less than ideal to handle it. Yet it is this system that responds to thousands of people in a mental health crisis every day. In general, everyone in a mental health crisis gets routed through an emergency department. There, a person in crisis often waits between 18 hours and 3 days for connection to mental health care. This approach is difficult for patients and wastes a lot of resources. but the Crisis Now model outlines a tested and proven alternative. A way to improve crisis systems across the country by expanding the options for those of us in a crisis, while reducing overall healthcare costs by creating a true emergency crisis service. And there are big savings in the justice system too, while dramatically improving the experience of the person and their family members. Drawn from current national best practices in crisis response, Crisis Now focuses on 3 components that help ensure an appropriate level of care to anyone in crisis. Component 1, a crisis call center staffed by specialists that coordinate all levels of crisis care. They evaluate the current crisis and can support and stabilize up to 90% of the cases they get. Those that need more, get more, with these hubs dispatching appropriate resources and then supporting those resources in finding the best solutions. Component 2, 24/7 mobile crisis teams that work in the streets meeting people where they are and, for the majority, resolving their crisis right then. Dispatched by the call center hub, they lessen the burden on local police and reduce the stigma that some feel when a uniformed officer knocks on their door. Component 3, crisis stabilization locations, which constitute the retreat model, can offer short-term care for people who need support and observation regardless of their level of crisis. These programs operate 24/7 and are the right door to everyone in a mental health crisis, including those that may require involuntary treatment. These high-tech, high-touch facilities divert away from the emergency departments and jails while providing immediate specialized treatment. Police no longer need to decide between EDs or jail. The no wrong door approach reduces the time needed to handle these cases from hours to minutes and allows police to go back to supporting public safety, a role they're uniquely trained to do. Let's review the impact of the Crisis Now model in Maricopa County, Arizona, 4th most populous county in the U.S. In 2017, Maricopa County Police connected more than 23,000 people in a behavioral health crisis directly to crisis care, and those people were accepted 100% of the time. The Crisis Now initiatives saved the time equivalent of 37 full-time officers, reducing wait times in emergency departments for behavioral health patients by a total of 45 years, saving local hospitals and emergency departments a total of $37 million in avoided costs and losses, freeing them up to help the patients they're designed to treat, while routing behavioral health patients to a course of care that's best suited to their needs, and reducing Maricopa County's overall healthcare costs by an estimated $260 million, more than twice the cost of Crisis Now services. To learn more about how Crisis Now can make a difference in your community, go to crisisnow.com and download our white paper.
Okay, so I was fortunate enough to be on Julia Ratty for the record. I was fortunate enough to be part of a group that has been working through the the interim, so through the Legislative Committee on Healthcare, that participated with a group of folks from Washoe County who made a field trip to Maricopa County to check out the work that's being done in Arizona to change the system. Arizona was one of the earliest adopters of trying to look at how do we respond to crisis differently. And so there's the most data and research that comes out of Arizona. But since then, several other states have adopted this approach to crisis intervention. I was pretty astounded at the difference that they have been able to make there in terms of the outcomes for people who are experiencing a behavioral health crisis. And certainly in the year that this nation has experienced, and with the results of the George Floyd trial that we're all grappling with and faced with this week, I think there's been a growing understanding in our nation that law enforcement is not the appropriate tool in the tool bag, if you will, for crisis response. We have for too long not built an appropriate crisis response system that is based more on using behavioral health professionals and peers with lived experience. And instead, whenever we have a person who's in crisis, somebody calls 911, that operator on the other end says police, fire, or health emergency. And if it's interpreted as police or health, we're going to roll a law enforcement officer and an ambulance, neither of which are actually the appropriate tool in most behavioral health crises. And so this model, in this starting point, is continuing to evolve into how do we just roll the right resource in the very beginning. And so today's bill deals with the third part of the model, which are the crisis stabilization centers. And that's a critical part of the model in terms of when you do have somebody who's in a crisis, being able to divert them from either the jail system or the emergency rooms. I will be bringing a couple of other bills forward to you that will deal with the crisis call point of care, which is really the triage that will be making sure that the right resources are getting out. And another bill that will be talking about the licensing of the peer professionals, so those people with lived experience who would be part of that response instead of law enforcement in many cases. So this is just one. So with that, I'm going to focus just a little bit more on the system of care so you understand where this fits in, and then we'll talk about the specifics of this bill. So again, based on the Crisis Now model, the first step is that high-tech crisis call center. In Nevada, we have Crisis Support Services of Nevada, which is a statewide national suicide hotline, and that's a huge asset for us as a starting point. The next, in most cases in the model, so these are the four components. That call center, the mobile crisis, the crisis stabilization centers, and then they all have an underlying set of essential principles and practices that are critically important. So if we go to the high-tech crisis call centers, these crisis call centers have specialists who are behavioral health specialists who can do both the de-escalation of a crisis on a phone line as well as some follow-up case management and care, right? So we've helped the person to de-escalate, and then we're making sure that they're connected to whatever follow-up resources that they may need. That's the first important step. In the research from where this model is operational in other communities, 90% of the calls of somebody who is in a crisis can be stabilized over the phone and then can be responsibly triaged for follow-up care. What's an important part of this model is that the crisis call center is high-tech, and so because of that, they have a system in the background where they're communicating with all of the care facilities, and they know where there's outpatient appointments, where there's medication that can be accessed, and where there are beds that can be accessed. So if that person does need care, they can be immediately placed into that system of care. The next part is these, jumped ahead. The next part are these 24/7 mobile crisis teams. We've done some work in the state to set up mobile crisis teams. In the governor's budget last session, we created CCBHCs, which are behavioral health, community-based behavioral health centers. And one of the requirements in those is to have a mobile crisis team. So we've taken some steps forward. There's additional work happening now on how do we make sure that there's a good Medicaid model to reimburse for these crisis teams. And there's some work at the national level coming from Catherine Cortez Masto on more support for mobile crisis teams. But the concept is here, okay, for the 90%, we got them taken care of, but now there's the 10% that can't be stabilized over the phone. And so that high-tech, high-touch call center can dispatch a mobile crisis team. And that mobile crisis team is a behavioral health professional. So it could be a licensed social worker, a psychologist, a psychiatrist, an APRN with a psychiatrist endorsement, and a peer with lived experience. So somebody who is in recovery from a behavioral health disorder or a substance use disorder and can relate to that person in a very different way sometimes than a behavioral health professional, a differently situated behavioral health professional can. So that's the idea. And in this case, this is where you start to see the alleviation of rolling law enforcement at all, right? Or rolling an ambulance at all. If there isn't a medical emergency and there isn't a safety issue, but you have an individual in crisis, this is the appropriate team to deal with that crisis. And then that brings us to the point of this bill, which are these crisis stabilization centers. So then there's a small portion, about 1% to 2%, who can't be stabilized by either the phone or the crisis team, and they need to go to a facility. And in our current model, as the video indicated, they end up in one of two places. They either end up in the jail, because the behavior that is associated with their mental health crisis is perceived to be violent, or they are actually harming someone, or they end up in the emergency room so that they don't harm themselves. In either case, they typically end up in some sort of isolation, where there's a great period of time that they're getting no contact from anybody with the exception of just the checking in on vitals and making sure that they stay alive. In this model, they go to something that's known more as a living room model. So these are short-term, subacute, which are important sort of Medicaid terms, if you will, care for these individuals. And in this living room model, if you can just picture it, if it would be like this room, there would be recliners and chairs and tables set up that are set up for conversation. And the staffing, again, is behavioral health professionals and peers with lived experience. And the exact opposite thing happens. There's as much engagement as you can possibly do in 23 hours and 59 minutes. And that 23 hours and 59 minutes is important because once you get to past a day, then it flips you into other licensed facilities. So if somebody needs more than 23 hours and 59 minutes of care, then they can be leveled up to an actual inpatient bed. At that point, it's appropriate for them to go into an inpatient bed. But if they can be stabilized and leveled down, they can be discharged with, again, an appropriate case management plan, so they're connecting to ongoing outpatient services, medication, whatever their needs are for them to stay stable. In the 2019 session, we did legislation to create these crisis stabilization centers, and we didn't get it quite right. And so SB 156 seeks to get the crisis stabilization right. That's why I'm here with you today. Finally, I did just want to touch on the essential crisis care principles. Super important that whether you're talking about the call line or the mobile outreach team or the crisis stabilization, that these principles are important, that it's got a recovery orientation. But the idea going in is that people have the ability to recover, that it's trauma informed. Many of the folks who are experiencing a behavioral health crisis or a substance use disorder, part of the reason that is the case is they've experienced some sort of trauma in the past, that it has this significant use of peer staff. Again, I've said this many times, but I think it's a critically important piece. People with lived experience who look like, talk like, and have something in common with the folks that they're helping. A commitment to zero suicide and safer care principles, which is something that the HHS committees have talked about a lot. Misty Young and her work out of the Office of Suicide has done a lot of work on that. Strong commitments to safety, of course, and collaboration with law enforcement. So when that call comes in, it might come into 911, it might come into a new phone number that we're developing, 988, which is the other bill. But if those two systems aren't talking with each other and law enforcement on the street isn't aware of and collaborating closely with this parallel system, then it doesn't work. And we are very fortunate in the state of Nevada that we've created something called MOST teams, which is a social worker riding along with law enforcement. And they will be the critical connection between these two systems, along with the triage that has to happen at the phone call level to make sure that folks get into the right place. So that's the system. I think that's the last slide. So that's the system. So again, this bill, Senate Bill 156, focuses on the third aspect of the system, which is the crisis stabilization centers, making sure that we get the licensing correct. And the reason that it's important that we get the licensing correct is if we get the licensing correct, then these facilities will be more eligible for Medicaid billing, and Medicaid dollars will be able to flow through to create the business model that allows for these to be successful. The bill itself, as these crisis stabilizations were originally set up, we imagined them to be psychiatric hospitals, but that was a very narrow group of facilities that could actually step up and serve the role. So the whole purpose of this bill is to broaden the number of facilities that, as long as they meet the licensing criteria, could step up and fill the role of crisis stabilization centers. I very much appreciate the indulgence of the committee to take you through the entire crisis care model, because I will be coming back, and I'm hoping I'll be coming back before you with the other pieces of it. But today, it's a relatively simple bill on the licensing of the stabilization centers. With that, I will close my remarks, and I stand ready for questions.
Thank you for your presentation. And yes, I think that was a very good overview for what potential bills are coming also over later on in the next couple of weeks. Do we have any questions from members? I didn't receive any. Oh, I got one right there. Assemblywoman Summers Armstrong, go ahead when you're ready.
Thank you, Madam Chair, and thank you, Senator Ratty, for a very insightful presentation on a very sensitive issue. I'm Chandra Summers Armstrong, Assembly District 6 in Southern Nevada in Clark County. And this issue is of utmost concern. My district includes many of the community groups that serve people who are homeless, houseless, and many of whom have mental illnesses come to our community for assistance. My question is, do you see these mobile response units replacing the most teams? Because most teams almost always include a police officer to, and I don't know a lot about, I haven't asked for any data, but I'm not sure how that's being received and their success rates. If you have any information about that, I'd love to know. Thank you.
Thank you. So appreciate the question through you, Chair Nguyen, to Assemblywoman Summers.
Feel free to go directly to the member if you would like to.
Thank you, Chair. I appreciate the indulgence. Again, Senator Ratty representing Senate District 13. So the most teams were funded by the state, but then pushed out to the local level. So to get the data in terms of the effectiveness or the impact of the most teams, we would need to have the folks from Clark County and Washoe County come and talk about that. And so that would be, I think, a question to the chair if that's something that we can find time to do in the remaining, I think, 39 days that we have left in the session. That said, I, in Washoe County, in my role, work with, and I'm familiar with the most team there, so I will couch my comments to say I'm more familiar with the Washoe County most teams than I am with the Clark County most teams. And the answer is no, I actually don't see the mobile outreach teams replacing the most teams, and here's why. For some people who are experiencing a behavioral health crisis, there is a true public safety issue. And it would be inappropriate to roll a peer and a behavioral health professional into that situation. You can imagine issues around domestic violence that could be that situation. You can imagine issues where somebody is further along the suicide ideation process and is getting close to actually using a weapon to fulfill their own suicide, where, and you know, and I'm sure if I had a most team social worker here, they could talk to you about the wide variety of reasons why there are certain calls they would not want to roll on without law enforcement. So that's the first reason. So the way it would need to work is at that first level, when the calls are coming in, that triage is critically important, that the right questions get answered. And 911 systems are already pretty brilliant at this. They have very detailed sort of if this, then what processes and systems to kind of figure out what is the right resource to roll and to give the folks who are rolling the most information possible. So as they're going through that triage system, if this appears to be a behavioral health case that doesn't have a public safety issue, then it should go over to the 988 system and the suicide hotline system. But if it still has a public safety issue, we should still be rolling a law enforcement. And in the best case scenario, that's a most team that includes a social worker. So that then you have the benefit of the social worker and law enforcement in those public safety scenarios. The other piece that has happened in Washoe County that I think has been incredibly important is that for these officers who are rolling with social workers, it is an on-the-job training that is irreplaceable and priceless, because they get to see how the social worker is interacting with the person that they've come upon in this crisis, as opposed to how law enforcement will interact. And while I think it would be very difficult to quantify, I think we have seen tremendous benefit, at least in Washoe County, in terms of how law enforcement is starting to approach behavioral health crisis when they are paired with a social worker and what they are learning from that. So for the public health reason and for the training, because law enforcement is going to be the response for some of these calls, I think that we would want to have most, we would want to have triage and know when we have to roll most and when we have to roll behavioral health crisis teams. I hope that answers your question.
Do we have any other questions from committee members? Seeing none, we will begin testimony. Oh, no, okay, sorry. Thought I heard something over there. It's just Assemblyman Hafen being loud. If we could move to testimony in support, opposition, and neutral of Senate Bill 156, broadcast services, if we can go to the line for testimony in support. And I remind callers to please clearly state and spell your name and limit your testimony to 2 minutes.
To testify in support of Senate Bill 156, please press star now to take your place in the queue. Caller with the last three digits, 548. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
This is Joan Hall, JOANHALL, representing Nevada Rural Hospital Partners. Here today, very supportive of SB 156 and very appreciative of Senator Ratty for working on language to allow rural hospital involvement in this important process. These crisis stabilization centers are important in the crisis now system of care. I was very fortunate to have actually seen them in practice in Colorado, and the positive impact on patients in crisis, law enforcement, and EMS was phenomenal. I'm very excited to see the impact this will have in Nevada, and I urge your support. Thank you.
Thank you. Can we go to our next caller and support?
Caller with the last three digits, 964. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Madam Chairman and members of the committee. For the record, Mary Walker, MaryWalker, representing Carson City and Carson Tahoe L. We rise in support of SB 156 regarding crisis stabilization centers. There's also a letter of support from Alan Garrett, CEO and President of Carson Tahoe Health on Nellis. SB 156 is an important bill for expanding access to care for mental health services in Nevada. SB 156 allows hospitals, not just psych hospitals, the ability to provide crisis stabilization services with the proper Medicaid reimbursement rate. Several years ago, Carson Tahoe Health opened the Mallory Crisis Center to treat the most critical mental health needs in our area. The Mallory Center has helped alleviate overcrowding in our ERs and jails. And the best thing of all is these patients actually get the appropriate treatment they need through the Mallory Center rather than languishing in ER beds or the jails without treatment. Over the last several years, hospital representatives from Clark and Washoe counties have talked to Carson Tahoe's Behavioral Health Department regarding whether their own hospitals could open a similar crisis center. However, when it became known that Medicaid only paid observation or office visit rates for these crisis services, the other hospitals lost interest. We believe SB 156 will incentivize other hospitals to open their own crisis stabilization centers. It's a critical piece to access of care that is missing in today's healthcare marketplace. We'd like to thank Senator Ratty very much for bringing this bill forward. And thank you for your time today. I hope you are all doing well. Thank you.
Thank you. If we can go to our next caller and support.
Caller with the last three digits, 931. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
My name is Trey Delap, Trey, David, Easy, Lincoln, Adam, Paul, on behalf of NAMI Nevada, the state chapter of the National Alliance on Mental Illness, in support of Senate Bill 156. NAMI is a grassroots mental health organization dedicated to building better lives for the more than 400,000 Nevadans affected by mental health concerns. NAMI believes that public policies and practices should promote access to care for people with mental health conditions. NAMI supports the development and expansion of mental health crisis response systems in every community. As noted by Senator Ratty, SB 156 addresses the third core element of national guidelines for crisis care. Crisis stabilization programs should provide a no wrong door access to mental health and substance use care, including accepting all walk-ins, ambulance, fire, and police drop-offs. Data suggests that a high proportion of people in crisis who are evaluated for hospitalization, locus levels 5 and 6, can be safely cared for in a crisis facility, and that the outcomes for these individuals are at least as good as hospital care, while the cost of crisis care is substantially less than the cost of inpatient care and accompanying emergency department medical clearance charges, and reduces law enforcement as the primary role as first responder to behavioral health emergencies. A well-designed crisis response system can be the difference between life and death for people experiencing a psychiatric emergency. SB 156 advances an essential piece of an effective community-based response so that all people have access to the right treatment at the right time. Thank you for hearing this bill, and we urge your support. Thank you.
Thank you. And I don't believe we have any other callers, but Broadcast Services, do we have any other callers in support?
If you've recently joined the call and would like to testify in support of Senate Bill 156, please press star 9 now. Caller with the last three digits, 900, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hello, this is Dan Musgrove. That's D-A-N, capital M-U-S-G-R-O-V-E. As the chair of the Clark County Children's Mental Health Consortium, as well as a member of the Clark County Regional Behavioral Health Policy Board, and representing a number of clients, including the Valley Health System of hospitals and West Care, the idea that the legislature has been working on for the last two sessions, the Crisis Now model, is so very important to the system of care that we have in Nevada, especially in Clark County, where hospital emergency rooms are always those that need care in a much better location than those hospital EDs can provide. And I just want to compliment Senator Ratty for her leadership on this subject, as well as the legislature, and we are absolutely in support of moving in this direction. Thank you.
Thank you, Mr. Musgrove. Do we have any other callers in support?
There are no more callers in support at this time.
Do we have any callers in opposition at this time?
To testify in opposition to Senate Bill 156, please press star 9 now to take your place in the queue. Chair, there are no callers in opposition at this time.
And do we have any callers on the line in neutral?
To testify in neutral to Senate Bill 156, please press star 9 now to take your place in the queue. Chair, there are also no callers in neutral at this time.
Thank you. And I saw Mr. Young patiently waiting on the Zoom. I don't know if he was here to just be available to answer questions or if he wanted to provide testimony in neutral on this bill. If you do, I'd ask you to unmute and go ahead.
Chair Glenn, no, just thank you, and to the senator. We're just here to answer questions, but of course, this is good policy and there is no fiscal note. This will help a lot of providers. The changes in the bill help a lot of providers, particularly those servicing the rules, to be able to utilize this model and receive reimbursement from Medicaid.
Wonderful. And I will turn this over to you, Senator Reddy, for any closing remarks.
Thank you, Chairwoman, again, Julia Ratty, for the record. First of all, I need to correct myself because I got a text during my presentation. So I'm using the term social worker too loosely. My apologies to Assemblywoman Benitez Thompson. The most team members who are the behavioral health specialists are licensed clinicians. Some of them could be licensed clinical social workers, but they are licensed clinicians, not necessarily all social workers. So my apologies to the most team members for not using that term correctly. And then just wanted to say thank you to the committee. While there is no fiscal note, a critical piece of this is that the billing of Medicaid is, and you're just shifting it from putting it in a more expensive part of Medicaid to a more expensive service to a lesser expensive service. And so over time, I do believe that there will be savings, but we're still standing up the model and all its components. In Phoenix, from the time they started working on it until the time they had it fully in place was about a 13-year time frame. We're about 3 years into the process here in Nevada. I think we can accelerate that significantly by being focused in our work and because so many folks have gone before us. I just am sincerely grateful for you to make the time for me today to present this bill, and I hope that you will find your way to supporting it. Thanks so much.
Thank you, Senator Ratty, and I know that we will be seeing you quite a bit in the next coming weeks, so thank you for that. With that, I will close the hearing on Senate Bill 156. At this time, we will go to the lines if there are any callers in public comment. As a reminder to callers in public comment, please state your name for the record and limit your testimony to 2 minutes. Broadcast Services, is there anyone on the line in public comment?
If you would like to participate in public comment, please press star 9 now to take your place in the queue. Chair, the public line is open and working, but there are no callers wishing to participate in public comment at this time.
Thank you, members of the committee. At this time, that concludes our meeting for today. Our next meeting is going to be Monday, April 26th. I'm presenting a couple bills in the Senate, so our Vice Chair Peters will be chairing that meeting for probably most of it. And meeting is adjourned. Have a good weekend.